to our December 3rd grand rounds. We've got Dr. Eve Valera today from Harvard Medical School. She's going to be speaking to us on ADHD. She is a cognitive neuroscientist with training in clinical neurophysiology, psychopathology, traumatic brain injury, and neuroimaging. She has published extensively on ADHD or ADHD-related behaviors and has led several NIH-funded neuroimaging grants aimed at understanding the neurobiology of ADHD in adults with a focus on the cerebellum. Welcome.
Thank you so much for having me, Kathy. I'm truly delighted to be here. And thank you to all of you who have come to this grand rounds. I am happy. So my objective today is to bring information to you about ADHD, and hopefully it will inform your practice or even just your life in any way. And so I'm always happy to take questions as they come up. I have a bunch of slides, needless to say, but I don't feel compelled to get through everything if other things are more important or you're interested in hearing something else. So feel free to ask for clarification on anything, and otherwise I will just proceed and can take questions for whenever. Okay, so I'm going to share my screen. All right, so this is just to say that I have financial support in general. I've been supported by my ADHD work in the past quite a bit. Currently, I do not have support for my ADHD work. I'm primarily working in another area at the moment. I'm doing both. I'm publishing in both areas right now, but the grants that I have are primarily looking at the effects of brain injuries in women who've experienced partner violence. So that is how I am currently supported. And I've received honoraria or travel funds for the, basically for the IPV TBI work from these, I guess, institutes or organizations or what have you listed below. And I don't think I need to read through all of them. I'll just leave them there for a minute so you can see. Some of them are a few of them are actually from Canada. One from Paris. Yeah, it's interesting to see these all here. So anyway, so if that's all good, then I will proceed. So just briefly, I have no financial conflicts or conflicts of interests for my ADHD work at all. Okay. So I'm going to be talking about attention deficit disorder today. It's not just for kids. And it's true. It used to be considered something that was just for kids or only seen in kids. But in the last, I'd say it's really been 20 to 30 years, we've recognized that ADHD exists in childhood and persists into adulthood for a reasonable number of kids. And there's actually a few folks who seem to have something that's ADHD like when they get older, but that might be, we don't know if that's sort of the same thing or not. So what is ADHD, or attention deficit hyperactivity disorder? Its definition has changed a little bit in the last, I'd say, what is it, maybe 5 years or so, with the addition of the DSM-5. It's still mostly the same, but there are a few changes. And so I'll just go through the current diagnostic criteria, and I'll mention some of the changes as they seem reasonable. So ADHD, as you might imagine, is characterized by problems with inattention and or hyperactivity and impulsivity. Okay, it doesn't have to be both. I think some people think if you have a problem with inattention, it's just attention deficit disorder, but that's not actually true. It's all semantics, but nonetheless, it's even if you don't have any hyperactivity or impulsivity, it's always going to be called attention deficit hyperactivity disorder. There are what we call 3 presentations. They used to call them subtypes, but they changed the term to presentations because what they realize is that how ADHD may look over the course of an individual's lifetime may change So whereas you may have something that looks like ADHD with hyperactive symptoms, or maybe hyperactive and inattentive symptoms in your childhood, when you get older, it may be that now you only have inattentive symptoms. So they've changed it from subtypes to presentations. And so if you have inattentive symptoms, you have the inattentive presentation. If you have hyperactive symptoms, you have the hyperactive presentation. And as you can imagine, if you have both inattentive and hyperactive symptoms, then you would have what they call the combined presentation. So what does inattention look like in ADHD? Well, and I'm going to talk a little bit about how this looks with kids and adults, but sort of focusing on how it may look in adults, because I think that's a little bit less recognized. So first, fails to give attention to details, makes careless mistakes in their work. So as a kid, it would just sort of be, it might be in their homework or in classwork, they're failing tests because they know the information, but they didn't pay attention to exactly what the question stated. This is similar to adults. So you might be at work, and especially if you have to deal with numbers or other things where details matter, you may get in a lot of trouble because you miss things if you have the inattentive subtype. And folks have been known to get fired or have significant work problems because of this lack of attention to detail or the excessive number of mistakes that they may make at work. Difficulty sustaining attention. This could be during tasks or lectures or conversations. So for some of the adults I've spoken to who have had ADHD, the idea of sitting through a lecture that's 3 hours long would be pretty much impossible. That might be hard for a lot of us, but that would be sort of like torturous to some people who have ADHD. And even an hour, some people may feel like they have to get up and go to the bathroom just because they don't pay attention. They're gonna be daydreaming and looking somewhere else. They just know they're not gonna be able to sustain that kind of attention. Does not seem to listen. So you could be talking to someone, and even though there's no extraneous stimuli that seems like it should distract them, because we know we all may look away if something distracts them, if something is distracted, and then that doesn't seem odd. But you may be talking to somebody and you sort of see this sort of glazing over and realize, when you ask them another question, that they really haven't paid much attention to what you've said. And that just happens. And so it can be very frustrating for some people because they're talking to somebody thinking they're actually having a conversation with that person. And then they realize that person hasn't paid attention. They may say, oh, I'm sorry. I have no idea what you just said. Does not follow through and fails to finish work. This is probably one that people are less maybe familiar with in a way. But basically what this involves is just for some reason, individuals with ADHD will often start tasks and just not finish them. And it could be for a number of reasons. Like it's just like the sustained attention part of it. Like it's just not interesting anymore, so they don't do it. Or there's just something else. It's just the last part is often very hard for folks to get through. I've spoken to people like, oh, I can't even tell you how many projects I've started and they're just unfinished. And so that's a characteristic of someone who had the inattentive subtype or I should say presentation of ADHD. Difficulty organizing tasks and activities. So this could be in the way of, say, for example, you might have a family trip. Somebody with this issue would not even try to plan it because they just know they're not going to be successful at doing it. Or if they try, they may fail miserably. And in everyday life, it may be not being able to plan ahead well enough to make that deadline that you're supposed to make, or to figure out how you're going to get certain activities or chores done. And so it's just very hard for them to manage everything and put it in their day in a way that will actually work. Avoids tasks requiring sustained mental effort. It's just, so some people may get tired chopping wood, for example, or running. Folks with this problem will just be like, they might tell me, I can't tell you the last time I tried to read a book, because, used to have to stay focused on that. It also, coincides a little with sustaining attention. but it's very hard for them to stay focused and mentally challenged. I mean, reading, if it's a fun book, it may not be challenging, but I say it's a difficult task or something like that. It can be very difficult. For example, reading a journal article where it takes a lot of cognitive effort may be very difficult for somebody to get through. And they may say, oh, I just look at the abstract, I kind of poke around and look at the conclusions, but I don't have the capacity to sort of read carefully everything. And often loses things. So this could be wallets, car keys, cell phones, materials that you need to do your work. In childhood, it's, you can hear people say, oh my gosh, I can't remember how many sweaters I lost. I never had the things that I needed to have in my book bag, etc. And in adulthood, it's the things that I just mentioned. So, and it's not necessarily losing them permanently, but it's losing them to a degree that it interferes with your life. So you can't find your keys. And so you end up being late every day because you have to spend 10 minutes looking for your keys because you just don't know where you put them, or your phone or whatever else. Or you show up for work and you don't have your badge because you forgot it and you didn't know exactly where it was. You thought it was in your car, but it wasn't. Then you have to go home and get it. Things like that. And easily distracted by extraneous stimuli. I think, and this certainly can be the case for a number of people. I mean, I think a lot of us might be distracted, but the key word here is easily. And so it's sort of like almost anything that comes by. If there's a squirrel out there, if you have a window, somebody who has ADHD is like going to be, oh, what's that squirrel doing? And then next thing you know, they've missed, 5 minutes of class because they were focused on what the squirrel was doing. Or if a janitor goes by, even less interesting. Oh, what's going on out there? Just being distracted. So it takes your mind off of whatever it was supposed to be focusing on. Next thing you know, you have no idea what's going on. You've missed a chunk of what was supposed to be paid attention to. And then forgetful in daily activities. This would be an example of forgetting you have the appointment scheduled. And despite the fact that it's in your planner, it's on your phone, whatever it is, you just forget. It just doesn't get done. So this could be like chores that you need to do. You said, you had to get this done for some reason, or a meeting that you had, or laundry that you were going to pick up, or something like that. So those are examples of things that somebody might experience if they have the inattentive form of ADHD, or the inattentive presentation. So what does hyperactivity or impulsivity look like? It's, as you might imagine, some of the following: often fidgeting, tapping, or squirming. So as kids, I'm sure we've heard stories of the kids who just absolutely can't sit still. They're running all over the place and going bonkers. You might say the technical term, bonkers. And sometimes we wonder, like, oh my gosh, like I'm glad I don't have that kid. And in adults, it may be, it's typically going to be a little bit different in that they may fidget it in their chair. I mean, I'm not in a very comfortable chair because I don't have a good one in my house. So I probably fidget more than I should in these situations. But this would be someone who's fidgeting no matter what. And then as an adult, you sort of learn that certain behaviors are a little less acceptable. You control them a little bit better. Your frontal lobes have developed a little bit more. So maybe instead of like fidgeting obnoxiously or whatever, you might do another type of thing, which might be something like, or tapping your finger or your foot. And so it's more subtle, but you're kind of always maybe moving. And it could also be a little less of the actual fidgeting, but more of a feeling the need to fidget a little bit, or just the feeling sort of a little discomfort in actually staying totally still. So this brings us to the next one, often leaving seat. And so this would be an example that this could be problematic, as you can imagine, if you're in a meeting where you're with your boss or whoever, and a group of other people, and you're supposed to be there for, say, an hour, and it's very hard to just stay in your seat, and you feel like you have to get up. And so the excuse might be, again, like I said before, you may have to go to the bathroom or something like that. It's just very hard to stay seated in one spot for a long time. And this is a little bit more descriptive of children, so runs or climbs in inappropriate situations. We've seen this, and I think people can say, oh yeah, we sort of see this in kids. And in adults, it may be less as you can imagine, less likely to be running or climbing necessarily, but sort of this incredible sort of just intense desire to just move more, not it just sort of staying still feels more uncomfortable for them than it does for the average person. And you sort of have this internal energy that's driving you. And some of these, as you can see, sort of tie together. They're just manifest a little bit differently in some cases. Unable to play or engage in activities quietly. So here it might be somebody who just is kind of very loud, or even if you're in the library, you're supposed to be quiet, you may tend to hum or make some other type of noises. It's unclear exactly why. I mean, there's some theories about how this may link into sort of just this idea that they need to have something going on in their head. So maybe listening to music may be helpful for individuals who have this form of this presentation of ADHD. But they're often making more noise than the average person as an adult. Often feel on the go, or as if they're driven by a motor. Again, getting back to this really restlessness. It's just like, oh, I got to do this. It's like, this might be somebody, you may know somebody who just kind of can't, they kind of don't settle. They kind of can't just sit down, relax and watch a movie for an hour, or just have a cup of tea and enjoy their time. They're like, I gotta go. I gotta get this done. Used to this driven by a motor feeling, and they will say, yeah, I definitely feel that way. Talking excessively. These are the people who you may not be able to get a word in edgewise. And they will talk in any situation, even if they're not necessarily invited to talk in that situation. And it bleeds into the next one, which is often blurts out answers. So instead of raising their hand and waiting for the teacher to pick on you, or the boss to say yes, or you're waiting, sort of waiting when you should be, when you should speak, but you speak out of turn. This would be an example of sort of this impulsive behavior. And then there's also difficulty waiting turn, which is related but can be different. So in this example, I've had people say, oh, if I get up to the register and there's like one or two people in line, I just put the stuff down and leave. I don't have time to wait in line. I can't do it. Or in cars, waiting, at the gas station or something, or just waiting, for their turn to, at a stop sign or something, may be very difficult. And then often interrupts or intrudes on others. And so this would be in a case, when I've had people who are just like, they make a couple of people maybe speaking, and someone with, this challenge or difficulty may just walk up and be like, oh yeah, hey, blah, 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 and start talking about their own thing. No consideration or contemplation for the fact that these other two people were engaged in a conversation that they were engaged in and enjoying, and then this person came over and just decided to say, I'm going to start talking to you. And it's just sort of a lack of I don't want to say it's a lack of consideration in a mean way, but it looks that way, because this is just sort of, it's just kind of the way they may behave. And so those are examples of inattentive and hyperactive behaviors that one might see in an adult with ADHD. I mentioned some kid stuff, but again, I'm not focusing on that as much today. And so some of you may be saying, they're saying, well, gee, I mean, I do that sometimes, or, well, I know some people who are like that, but I don't think they have ADHD. And you're probably right, because it doesn't mean that if you have any of these behaviors, you have ADHD. And here's where we get down to what the additional criteria are. So age 16 and younger, you need the presence of at least 6 inattentive or 6 hyperactive impulsive symptoms. So you can't have 3 inattentive symptoms and 3 hyperactive symptoms and get the diagnosis of ADHD, or at least you shouldn't, right? Because that's not the criteria. So if you're age 16 or younger, you need at least 6 to get the inattentive presentation or to get the hyperactive presentation. And if you have 6 in each, you get the combined presentation. And that does actually I have seen people who have that. Now, because of this growing appreciation for ADHD persisting into an adulthood, there has been research looking at ADHD in adults and saying, well, you know what, sometimes what we see is that they have 5 symptoms, but they still seem just as problematic in terms of how it affects their lives and it being an impairment for them. So does this mean they really don't have ADHD? So what happened is in the DSM-5, they changed the criteria. So now at age 17 and older, you only need 5 symptoms in one of each of the categories, okay? Just sort of the idea that some of the things as you get older are still problematic, but partly probably because your frontal lobes have developed more, you can either deal with them a little bit better, or there may be other neurodevelopmental things that happen that just make it that it's still a problem, but you don't necessarily need to have all those symptoms. And here is another very important thing to consider. Symptoms need to be present for at least 6 months to a degree that's inconsistent with the developmental level. So that's important, because if you have a 2-year-old and you expect them to do all sorts of things like, oh, I just want you to watch something for an hour and not bother me. Well, that might not be good. Or if you expect a 2-year-old not to interrupt you or not to blurt out answers. So in other words, some of those behaviors are very appropriate for a 2-year-old, right? And so you have to recognize what's appropriate and what's not. And as an adult, most of those behaviors are not necessarily appropriate. But it just goes to show that when we're talking about any age and kids, which I'll get to in a second, why this is really important, included, it has to be inconsistent with the developmental level or you shouldn't be getting the diagnosis. And also, it needs to cross at least 2 settings. This is because it could just be that there's some environment in which the individual just is having problems. We don't know exactly why, but it's not necessarily that person per se. It's the environment that drives these behaviors. And so to be diagnosed with ADHD, you need to have the presence of these symptoms in at least 2 settings, which could be home and work or home and school, or social, a social setting and home setting, but you have to have it in at least 2 settings. And then this is a criteria that changed. It used to be prior to the age of 7, where you needed to see the presence of these symptoms. And the DSM-5, they changed it prior to the age of 12, again, recognizing that sometimes these symptoms develop a little bit later, or it may not necessarily, even if it's not that they've developed later, they're being recognized a little bit later. And what had happened historically is that we were seeing cases where folks would have these symptoms at the age of, they couldn't go back to the age of 6 or 7 to say, yeah, I had all of these. But they'd be like, it may be age 9 or 10 or 11. And that's like, okay, well then is this ADHD or not? Because we don't know if it's meaningful. Are we getting past a certain age? And the work that was done basically showed that there wasn't really meaningful differences between the folks who had these symptoms by the age of 7 or folks who had these symptoms by the age of 12. So in their later life, it was still a problem regardless. And so they changed the criteria to reflect that. And so that was one of the several moves that were made going from DSM-4 to DSM-5. And then finally, need clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And again, this is really important because if you have somebody who has these symptoms and no one, or a handful of these symptoms, and they're in environments which it works, right? And some people have, with ADHD, have said, well, I do this because this allows me to succeed while, despite the fact that I have the ADHD. And in that case, so do you really have ADHD? And so the point is here is there should be interference. There should be reduction in quality of life in at least some area of function. And if there isn't, then you don't technically meet the criteria for ADHD. And this comes down to being important if it's like, well, should you give someone medication or not? It's like, well, if it's not impairing them, should you give them medication? Not necessarily. Do they need treatment? I wouldn't I wouldn't say so. I mean, I'm not giving any advice or anything, but if you were to ask my personal opinion. So the point is when we talk about ADHD, unfortunately, I'm not sure why, but ADHD is one of those disorders where in kids even, there has been this resistance by some folks to the idea that ADHD exists even in kids. And in adult psychiatry conferences, I'm sorry, in child psychiatry conferences, sorry, there will often be picketers outside saying, stop poisoning our children and things like that, because they know at a child psychiatry conference, a lot of what's going on is going to be talking about ADHD because it's a very common neurodevelopmental disorder. And it's unclear why, because there's lots of evidence, any evidence we have for any other disorder is, people for depression or anxiety, et cetera. And we have the same type of evidence for ADHD, yet there's this resistance to accepting it as a bona fide problem for which people may need help or treatment. And so in adulthood, there could be the same, there's not necessarily people picketing because it's not kids, but there's also like, well, are you really just being lazy? I mean, oh, come on, this is just an excuse. And, what we like to say who study ADHD in adults is like, no, I mean, if, do you question whether somebody has depression if they say, I can't get out of bed in the morning, I just never want to eat, I think I'm worthless. You don't say, oh, I think you're just making stuff up, right? You don't say, you say, oh, wow, I feel bad for you. Maybe you should get treatment, maybe you should get help. But with ADHD symptoms, it's not necessarily considered that. I mean, we hope that's changing, right? But we need to recognize that this is really a true disorder, just as true as any other disorder that's out there. So we need to start recognizing it more. And as I go through the next few slides, what we'll see is that there's actual comorbidities. So someone with ADHD may also have depression or anxiety or something else that's basically potentially almost masking it, in the sense of somebody may think that, well, this is just somebody who's depressed, and there are some overlapping symptoms in a way. Well, not so many here, but the bottom line is, if you just think, well, that's their problem, and don't think that maybe something else is going on, they may be depressed because they have all these other problems which have been making their lives kind of miserable for a while. And so it's definitely good to consider and to pay attention to whether or not any of these other issues are occurring, especially if you have somebody who's sort of like, I'm scratching my head, I can't figure out what's going on here. So it's estimated that 8 to 12% of school-age children have ADHD, and 5% of adults. Okay. And what we see is ADHD behaviors across the lifespan, and they change a little bit, but you could see based on what I was already saying, depending on where you are in your life. So when you're in school, when you're younger, you may see this in the form of repeated grades or getting F's on report cards, notes from the school that your kid's having problems. This is Johnny's a troublemaker, etc. Kids have low self-esteem. So needless to say, if you are not doing well in school, and then there are social issues, some of these behaviors, especially some, if you look like you're not paying attention, or if you're constantly interrupting, may be really annoying to other people. And so you may not have a good social network. Maybe various things may contribute to low self-esteem in individuals who have ADHD. And then poor peer relationships for some of the reasons we were just stating. And you can imagine how it could be difficult to be with somebody who's like this for a number of different reasons. They're never on time. They can't keep their appointments. They're always having problems with their job. And this isn't a criteria, but I will say there is a component. There's a bit of a social emotional component to ADHD, in which, for lack of a technical word, I'll say sometimes they may seem a little quirky, but it's not in the criteria right now, so I don't talk about it too much, but there is something there that then makes relationships, it's just, when somebody's a little odd, I mean, you like to click with people, and so they may be less likely to click with people. And part of this is going to get to, I'm actually not going to have a lot of time to talk about it, but the cerebellum and the theory of timing, the cerebellum. Individuals with ADHD have higher rates of substance abuse. And so you have bad grades, you have repeated grades, then you may have low self-esteem, poor peer relationships. Maybe now you start to self-medicate because you feel like you just have these issues, you have this drive, and substances help control that, or because you have these other things. But for whatever reasons, there's a high comorbidity with ADHD and substance, alcohol, and or drug abuse. Greater rates of psychological maladjustment, which I've already touched on in the context of increased comorbidity with problems like anxiety and depression. And employment difficulties. It's interesting that the folks that I have spoken to who have ADHD will often may have several jobs, or like odd jobs, or maybe these are the folks who like to work overnight, or they have jobs that allow them to be very active or not have a set schedule or something like that, because something like that, would just about kill them if they had to do this as exact time from this to this. They just couldn't take it. At the same time, because they may be impulsive, and blurting out answers, not paying attention, they may have problems with work, getting fired for lack of attention to detail, or for being rude or impulsively quitting or something like that. They have greater rates of traffic violations, crashes, and injuries associated with those crashes, despite the fact that when you test them, they actually know the rules of the road just as well as other folks. It's unclear. I don't know if there's been any recent data trying to determine that, but you could see how either impulsivity or hyperactivity or inattention could drive this. So you could say, or sort of distractibility. You could be driving along and say, oh, look at that cute little doggy, and you crash into something, right? So that's one example. Or it could be that you're just really needing to get somewhere, so you're driving way faster than you should, or something like that, and then you crash. Or you don't notice that the light has just turned red and you go through it. So, and higher rates of multiple marriages. So this sort of gets back to this issue of poor peer relationships and this sort of potential social quirkiness, and just living with somebody who has ADHD might be taxing. Or, it's just, as you can imagine, when there's not a consistency or when there's impulsivity, it can be challenging to maintain relationships. And then neuropsychological deficits. About 30% of individuals with ADHD have been shown to have what we'd call executive functioning deficits. And if anyone who knows about neuropsych and what executive functioning is, that's really, really important. Executive function involves this ability to plan and control and basically carry through with things. And so if you are lacking executive functioning capabilities, then that's going to make things much more difficult for you in general. And so I'm looking at the time, and I have about 15 minutes, a little less than 15 minutes left to talk. And there's a ton that I could talk about. So what I'm going to do is, first, I want to ask if anyone has any questions right now. We'll have 15 minutes at the end, but if anyone has anything they want to ask me right now, I'll just say you can, I don't know, blurt it out or whatever.
Unmute or put it in the chat, maybe.
Yeah, whatever you want. And if not, what you can do is you can stop me too. I'm gonna go on. But for the next little bit, does somebody have something in the chat, or was that already there?
No, that was me.
All right.
Sorry.
No worries. Okay, so for the next bit, since I am being mindful of the time, what I'm going to do is summarize a lot of the slides that I have here. And the objective here is to convey to you the potential importance of the cerebellum and what we think the cerebellum is doing in understanding what's going on in ADHD in adults or children. And so the reason I kind of got into this and really picked up on the cerebellum was because it started with this meta-analysis that I did. Basically one of the findings, I will like to point out that most of the data if you look back, I mean, more recently, it's been a little more evenly distributed, but most data on ADHD is in males, in part because males, there's a greater prevalence of ADHD in males, especially in childhood, although it evens out. It's not even, but it's less less of a difference in adults between males and females. But basically what happened was is people saw ADHD as an ADHD as a disorder in kids, and mostly with males. They would just exclude females because they didn't really know what to do with it, or they just wouldn't be able to recruit that many. So, if we look here in 21 studies, 81% of them were male, and this included all of the structural imaging data at the time when I did this. So whatever I say in terms of neuroimaging, we always want to keep that in mind, that it may apply more to males than females, except for this one study where I actually looked at sex differences. But basically, if we look here, what I found in this meta-analysis was that we knew that prefrontal regions should be implicated in ADHD for various reasons. But one of the findings was that the cerebellum and the cerebellar vermis and other subregions of the cerebellum were really prominently shown to be reduced in individuals with ADHD, or at least in these studies. And so it's like, well, that's really interesting. So what is going on? And so when we look, what I did was we continued actually doing that research. And or what I did was I was doing a neuroimaging study, and I continued doing this research. And what since I was doing this, I made sure I oversampled females, so we're almost half and half. But basically what I did was I used a working memory task to try to see if we could find differences in neural activation in individuals, adults who had ADHD versus adults who did not have ADHD. And so we had males and females, and we were expecting to find differences in the right prefrontal region, where we know working memory sort of is, it's specified for working memory. I mean, and I hate even saying that because we know really all cognitive functioning is really based on networks, but nonetheless, in terms of the localization that is there, we can go with that region. And so what we were expecting was regions in the right frontal cortex. And what we found instead was left lateral cerebellar cortex was showing less activation in the adults with ADHD than the controls. And then this says without any LD, because we also looked at this, we made sure that these folks didn't have learning disabilities, because learning disabilities are highly comorbid with ADHD as well. And so this was really interesting because we weren't necessarily expecting this, but we said, okay, well, this is what we have. But when we focused in on that right area, what we found was that indeed in the right dorsolateral prefrontal cortex, we did see some reduction in activation for the ADHD adults. It wasn't statistically significant, but it was shown as what we'd call a trend level. So it's close. And the idea might be, well, if we had more subjects, maybe we would see something, but we don't have quite enough here. And so what is really interesting about this is we had a region potentially showing reduced activation in the right prefrontal cortex and the left lateral cerebellum. And the cerebral hemispheres are contralaterally connected to the cerebellum. And I'm going to tell you more about the cerebellum in a minute, but it's almost like a little mini brain. And it also has two hemispheres. And so basically when we're looking for connections, we would want to see, if we're looking for something that we think is a network or a pathway, we'd want to look on the right side of the cerebrum and the left side of the cerebellum. And that's because we have what we know are these frontocerebellar and also parietocerebellar, all sorts of circuits in the brain. So in this particular case, what it looked like was we had an example of recognizing a circuit that may be faulty, abnormal, in the ADHD adults' brains, because we know that we have neurons that start out in the frontal cortex, they come down, they project down to the pons, and then they go to the contralateral cerebellar cortex, the deep cerebellar nuclei, and then they go back to that same region in the frontal cortex via the thalamus. And so we know that there's these loops, these corticocerebellar loops that exist in many places in the brain. And these data suggested, wow, this is what we have here. Now I continued with these data. I'm again being mindful of time. And I wanted to look at sex differences because, as I said before, most of what we knew about was in males. And so I'll just make a sort of a longish story short. When we just looked, I had 44 ADHDs and 49 controls, which is a really big sample at the time. Now there's these massive data sets, so it wouldn't be so big now, but nonetheless. And what we saw when we just looked at everybody was, well, we see frontal, reductions in frontal activation during this working memory task. It's like, okay, but where did that cerebellar region go? Because now I was expecting it, right? I said, oh my gosh, that was the main thing we saw before. Where did it go? Well, lo and behold, if you look at males and females separately, and these are just images, what we see is and I'll show you the, the comparison in a second, but we can visually see that there's a number of regions where there's relatively reduced activation in the ADHD males, but nothing comes up as being significantly reduced in the females. And then if we look at where the ADHD males are showing greater differences in controls than the females were, we see these, again, these left-right patterns. This is a nice one where you can see here, the right sort of subcortical cluster. And here you see the right frontal region, and then you see the left lateral cerebellum over here. And so again, it's very consistent with that circuit. So these data were the data that made me say the cerebellum is really super important in ADHD, or at least I think it is. And it wasn't just those data, but it was the fact that I started looking into this and realizing, wow, this really makes sense. So the cerebellum is incredibly underappreciated. And I would say it seems so almost, too simple to try to describe where the cerebellum is to a group of adults. But I have to say it's not, because a lot of people don't know where the cerebellum is. And I think since I know, and it seems like so obvious to me, but it's actually not. And if you know, you're doing great, because people don't necessarily understand where the cerebellum is all. I mean, granted, they don't necessarily understand where the other lobules are either. But even if you look at historical pictures, the cerebellum might be just left out. Or if you look at some people's pictures of the brain, sometimes it really looks just like this, where people don't even include the cerebellum. And what we're finding, at least what I'm finding, is that the cerebellum really does seem to be important for a lot of things. And this isn't just for ADHD. It's, there are a number of psychiatric disorders for which we feel the cerebellum is playing some role in the pathophysiology. Even in schizophrenia, that was Anderson picked that up as a potentially major player quite some time ago. So at any rate, the cerebellum is actually I'm not going to say too much because we're running out of time, but it's actually a really complex yet simple structure. It's complex in the way that it has 10 lobules that goes from the top to the bottom here, lobules 1 through 10, and then you have what we'd call the anterior lobe and the posterior lobe. Obviously, this is just a schematic. It's not really what it looks like because it's hard. It's so convoluted on itself. It's hard to represent it in a flat image. But we have the vermis, which is the midline, and then the hemispheres. And so the reason I say this is because these things make a difference. It's not like there's just the cerebellum and it's this one thing that does motor control or balance, like the frontal lobes. Oh, well, that kind of does this, or the visual, the occipital lobe. Oh, the visual cortex is in there. That's vision. And whereas those things are true for the cerebellum, it's not at all true where you can just say, oh, the cerebellum is motor control and balance. In fact, if we're going to talk about motor control in the cerebellum, we're most likely to see it up here in the anterior lobules 4 and 5 or so. And then also there's a secondary motor representation in lobule 8. But out here, what we see is stuff associated with working memory, for example. And I could give you a lot more, but I know I'm running out of time. So I just want to say a little bit more, and then I'm going to summarize a lot of stuff. But I just think it's amazing that back in 1998, even Desmond Fees wrote this review, and they show that, and I think most of these controlled for motor functioning, And they show the cerebellum activation in all different regions of the cerebellum for non-motor tasks. And so here we see explicit memory retrieval here, both in the vermis and the lateral cerebellar hemisphere. It's lateral and intermediate. We see language and verbal working memory here. We see verbal working memory down here as well in lobule 7B. Sequence learning happens across the vermis and lobules. Trajectory or rotor pursuit motor learning, again, vermis and hemispheres. And then classical conditioning again. So way back then, there was this recognition that the cerebellum isn't just motor control, yet people still didn't really pick up on it, except Jeremy Schmahmann and colleagues at the same time were definitely picking up on this and writing about it. And Jeremy and his colleague, Janet Sherman, coined the term cerebellar cognitive affective syndrome. They had 20 cerebellar lesion patients. And what they noticed was that despite these being cerebellar lesions, these folks had problems with planning, set shifting, abstract reasoning, spatial cognition, memory encoding, memory retrieval, procedural memory, attention, linguistic functions, and personality changes. So you would expect this is the cerebellum, this would be motor. Nope, that's not what's going on here. And what they also discovered, and this is sort of a gross way of putting it, but nonetheless, I think still somewhat accurate. But the posterior lesions tended to be more critical than the anterior lesions. And the vermal lesions tended to be associated with affective disturbances, and the hemispheres tended to be more associated with cognitive disturbances. And if you look here, well, actually, you know what? I can go here because I'll tell you this actually really describes it well. Using retrograde transneural transport of the rabies virus, Strick and colleagues basically injected this rabies virus into different lobules of the cerebellum in a non-human primate. And what they found was pretty amazing. So basically, if you inject it into lobules 4 and 5 and 6, it goes to area M1, which is a motor region. And I'm sorry, in area 8, as I said before, that secondary motor representation, they go to motor regions, right? However, this region, this lateral cerebellar hemisphere, it's usually considered, it's called, you can say cruise 1 and cruise 2 or lobule 7. There's some different terminology, but nonetheless, you see the projections here going to area 46, which is the dorsolateral prefrontal cortex, which we often associate with working memory. So if you look here, there's very little overlap in what went to M1 and what went to area 46. And so it was really impressive. And so here it's just more evidence to show that no, the cerebellum is not just this one, region that's motor control or balance, or coordination. It really does have a somatotopic organization. And here what we showed, this was, I mean, it almost blows me away that we were able to do this. Much later than 98, but nonetheless in 2010, we basically mapped different types of cognitive or motor functions onto the cerebellum in individual subjects. And so here, basically we had a finger tapping task, and this is what we saw light up in the cerebellum. Lobules, basically, usually it tends to be lobules, 4, 5, or 6, okay? And we see the secondary motor representation down here in lobule 8 again. For our working memory task, we see the lateral hemisphere lighten up. And what's important is it's the contralateral cerebral hemisphere to where we would expect working memory to be in the cerebrum, which would be in the right. Okay. And then language is over here. Okay. In the lateral hemispheres. And then spatial, I'm sorry. I was wrong. I knew that wasn't making sense. Language we have in the blue, which is contralateral. because so language we know is on the left side in the cerebrum, so it's on the right side here. And in terms of spatial, we know that spatial is usually in the right in the cerebrum. It's on the left lateral hemisphere here in the green. So again, I was trying to go a little too fast, so sorry if I confused anybody. But the bottom line is the cerebellum is very complex. And the way I see it, and the way a lot of people see it, I think, is it's sort of like a mini brain. And it basically is connected to so many parts of the brain. It's sort of like what you get are is networks within the brain that involve both the cerebrum and the cerebellum. And if you have a disruption of those networks, you can have problems. So just like here, if we have this network, we have, this frontal region and then the cerebellar region. If you have a problem in the cerebellum, even though nothing may look weird in the dorsolateral prefrontal cortex, you may have a problem in working memory if you have something going on in this part of this circuit. And I'm going to sum up a lot of stuff right now in a few minutes here. But how does this link to ADHD? And there's a lot. I mean, there's a few things I'm going to show you, which I found before I started doing my research, and some stuff that confirmed hypotheses in my research. But if we look at animal models of ADHD, the most common model is the spontaneously hypertensive rat. Okay, and that's because, ADHD is, especially if you're thinking of kids, is really a lot about hyperactivity. Because in kids, you a little less focused on the inattention part because you're not necessarily expecting them to be so attentive in the younger years. So that was a common model. However, if you look at this other model, the developmental cerebellar stunting, this is another rat model, we see that lesions occurring in the later stage of development model hyperactivity and mild cognitive impairment that is very similar to what we see in ADHD. Also, in terms of the pharmacology of ADHD, methylphenidate, or when we say MPH, which is for many a drug of choice, especially in kids. In adults, it's a little bit of a different story, but I don't have the time to go into that, has been shown to increase cerebellar metabolism in both normal controls and adults. And Anderson and colleagues also showed a dose-dependent effect on vermal, or that mid-region in the cerebellum, T2 relaxation times, varying by levels of hyperactivity. So again, a couple of links there. So in the last 2 minutes, I'm just going to say the idea that I came up with, not that I came up with, but which I chose from potential ideas of what was going on, is that the cerebellum is involved in timing. And so because of that, we're having timing abnormalities in ADHD individuals that we're not necessarily recognizing. And so, as I've already said, the traditional view of the cerebellum as just sort of being balanced motor control, it's clearly incomplete, right? And so other ideas have been put forth about the cerebellum, and Hallett and Grafman and Rich Ivory have this idea that cerebellum is involved in the timing of motor and cognitive processing. It's the timing of motor and cognitive processing. So in much the way that the cerebellum, as we might expect, would be involved in a motor process. Like, so if you don't have a good cerebellum, you're not necessarily going to be able to, kick that ball right, or hit that baseball, right? And in a similar way, if your cerebellum is not working, you may not be able to do things smoothly in cognitive or social domains either. So that, think of it this way, the faulty cerebellum could contribute to deficits in cognitive and motor and social processing requiring timing. And I just sort of throw social in there because I don't think the data aren't quite the same, but we'll just say we'll call it my belief. And in terms of ADHD, what do we know about motor timing? Is there any evidence? And there is. It's mostly in kids, but it's because adults haven't been tested. Up to 50% of ADHD children have been found to have motor abnormalities in both fine and gross motor tasks. So these are just some examples: motor leg movement, Purdue pegboard test, dexterity tasks. And interestingly, in terms of cognitive timing tasks, ADHD children are shown to be impaired on a whole range of them as well. So motor timing, that could be finger tapping. There's a motor component of that clearly, but you also need to keep a certain pace. So there'll be a metronome where it's going beep, 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 and then it stops, and you have to try to keep that same pace. And so then your mind has to work to figure out how quickly you need to tap. So there's the motor, actually implementation of it, but also the timing aspect of it. And things like duration discrimination or duration reproduction. So duration discrimination might be which of these gaps is longer, beep, beep, or beep, beep. Now that one I made kind of obvious, but nonetheless, that second gap was longer, and individuals with ADHD would have a harder time with a task like that. And performance on these timing tasks is typically either slower or more variable. So we also see this in Eyeblind conditioning. We've seen that timing components of Eyeblind conditioning are significantly impaired in children with ADHD. A couple of folks have found that. And when we look at brain regions that have been shown to be abnormal, or that we know have been sort of like tested, and sort of people say, yeah, this is what ADHD is about: frontal, basal ganglia, and cerebellum. All of those are regions that are often involved in timing, different types of timing, but timing nonetheless. So I'm going to actually stop with that because I want to make sure people get a chance to ask questions. Then the rest of it was going to be me talking about a range. I'll just flip through these so you can see a range of studies that I did, all supporting this hypothesis of motor timing, either by looking at balance or finger tapping, or, and this is a functional connectivity that's related to the cerebellum and the default network. But all of these supported the hypothesis that timing is potentially abnormal in ADHD related to the cerebellum. And these are just some summary slides of those data, basically showing working memory and sensory motor timing tasks in adults that show abnormal activation in cerebellar regions. And then we have a clinical assessment of the cerebellar motor system, which might be done in an ataxia clinic. We were able to pick up motor abnormalities in ADHD that were associated with both symptom counts and subject variability. And the idea here is that I think we have growing evidence that the cerebellum is involved in the pathophysiology of ADHD, and we need to start understanding what that means in ADHD, because we're not going to fully understand ADHD if we don't pay attention to that. And I think that not just ADHD, but in psychiatric disorders more generally, if we don't consider the cerebellum, we will probably have incomplete or possibly wrong models that we're using to understand the disorder. And I think ultimately we may be missing opportunities for treatments by ignoring cerebellum as a potential target. A lot of people helped me with this work. I couldn't even put all of them on here, but these are just some of them. And with that, I do apologize because there's not a lot of time for questions, but thank you so much for your attention, and I will take any questions now. And I was hoping that if you really had burning questions, you would have interrupted me anyway. So I kind of went ahead with that a little bit, but I'm going to stop sharing, and I hope that if you have questions, you ask them now.
Could you maybe send me the presentation and I can forward it on?
Yeah.
Thanks.
Yeah, no, and that's one of the reasons why I do that, because I know I'm not going to get, it's sort of like one of those things where I know I don't have time to go through all of it. But if somebody says, oh, I want to hear more about your work, then I have it there. But if someone says, well, I really like seeing this background stuff, then I have that. So I'm always happy to share for whoever wants to see more later. No burning questions, huh?
Go ahead and just unmute yourself if you have any questions.
Either no one understood it or no one cared.
Why do we have so little research on adults?
We're getting more, but it's partly because it hasn't been considered a problem. You know, ADHD in kids has been perceived as a disorder for quite some time. And the idea that it persisted into adulthood wasn't really recognized until, say, like, I'd really say about 20, 30 years ago. And so there just hadn't been, you know, sort of an opportunity in the sense of it didn't exist. Right now that people are recognizing it exists, people are studying adults more. And the other thing that got adults into it was because when imaging came along, you couldn't, the PET, what we started with PET, and PET, you have to inject radioactive tracers. And so you couldn't do research on kids because no one, I mean, there were some things, but it was none of the data were none of the designs were good for various reasons. But nobody wants to have their healthy child serve as a comparison and get injected with a radioactive isotope so that they can be in a study. So what happened was adults, however, could be injected with that because they're adults, right? And so there was research that was being done on adults in neuroimaging, a little bit more than on kids at first. And then with the advent of functional magnetic resonance imaging, where you didn't have to inject anybody, then kids were being imaged, et cetera. So it's interesting, but nonetheless, the main answer to your question is that it's just not as common in adults, and it's not as recognized in adults.
There's a couple of questions in the chat. I don't know if you can see them.
Oh yeah, I will look. Okay, what are the implications of the involvement of the cerebellum for the treatment of ADHD? Well, that's a really good question. And I think that I think that what people just, in terms of folks who are treating ADHD, we need to recognize that as a potential target, because right now that's not really what people do. People are focusing on frontal regions, for example, and that's reasonable, but the cerebellum could be another opportunity. And we haven't, as far as I understand, there's been very little movement in terms of like a drug company or something saying, okay, we know that the cerebellum is important here. What targets the cerebellum? And then really trying to do that. There's also things that I think that, there's TMS or TDCS, these sort of magnetic types of TMS is transmagnetic stimulation. And so you actually have you put pulses on the head, on the brain. That's the idea. And that has been shown to, I haven't looked at the data recently, but have some efficacy, I think, in schizophrenia because they've looked at it there. But it's hard to know. I mean, that could be a potential treatment option. There could be something there by targeting the cerebellum and doing something like that in ADHD, which I don't think has ever been done. So I think ultimately the implication is that without considering that as a potential target, we're probably missing out on possible ways to get to the brain that something deeper in may be hard to get with certain methodologies. And then I would like to know what supports we have for adults and where to refer for support. So that's a great question. Now, where you are, I do not know where there may be adult support for adults. But I can follow up on that, because Kathy, I can work with you. There may be somebody who knows something, or maybe there's something that we can just say, well, it's, virtual down here or something. But obviously it's going to be sort of depending on what type of support you're looking for, it's going to be regional. But I can definitely, I'm happy to follow up on that because I think it is important. And any theories on how a cerebellum would become faulty in the first place? Well, it could, so the cerebellum is actually one of the last regions in the brain to fully develop. And so it may be that things that happen, in either in utero or like right around conception, or maybe during childbirth. I mean, I don't, it's hard to know exactly, but there's a greater likelihood for something to go wrong with the cerebellum and its development because it happens over the latter part of development, if that makes any sense. And it's also just the case that it's sort of like how does any of these regions that we know to be sort of faulty or abnormal, for lack of better words, that contribute to the disorders like depression or anxiety, how do any of them get to be abnormal, right? So I don't think we necessarily know these reasons. We do know that initially we know that ADHD is highly genetic. So it's about almost 80% genetic. So there's a huge genetic component. So if you have parents or family members who have ADHD, you're much higher likelihood of having ADHD or developing ADHD. But that means there's also room for environmental factors or epigenetics to occur. So anyway, so I don't think anyone really knows, but that's the best answer I can give there. And then I think this will be the last one. What are some of the non-pharmaceutical treatments for ADHD? There are a number of different things. There's cognitive training. There has been some neurofeedback training. There has been, now this, I don't think there's anything to really substantiate it. There's this DOORS program, but again, I wouldn't recommend that because I don't know if they've ever done studies. They say it works, but I don't know if they've actually done systematic studies to ensure that it works. Whenever you have a product that you say works, you should do a study, a clinical trial to ensure that it actually does work and it's not just a placebo effect or something like that. I'm not sure they've done any of that, but there are other indications that maybe some forms of biofeedback or cognitive training do work. And what the best things that have seemed to work, I think, and again, some of the cognitive training programs they're pretty intensive. And so it's a lot of time, there's parent time, and well, if you're kids, right? But there are, hold on one second. I'm supposed to be in a lab meeting right now and I'm directing it. So people are wondering where I am, but I know I went over, so I'm going to give you extra. Well, whatever. So the bottom line is, I think some of the best evidence has been that if you have some type of cognitive training as well as medication, then that might be most fruitful. But I haven't studied up on that. That's not my treatment, isn't my specific expertise. So I don't want to say too much on that. But yeah.
And that seems to be the end of the questions, and it sounds like you need to run, but thank you so much for presenting today. I know I certainly learned a lot, and it sounds like you've provided some questions for other members of the group. So thank you so much.
Yeah, so I mean, thank you all for being here. I really appreciate it. I hope you did learn something. And if you were interested in seeing more of my particular work, I'm more than happy to share, but again, I kind of put that there, knowing that, for an audience like this, it's probably less relevant, in the fact that it seems more academic than helpful to someone with working with their clients or patients. But feel free to reach out with any questions that you have. And I do hope that you learned anything. And if there's anything that I didn't mention that you want to know about, let me know.
Okay, thank you.
Thanks so much, Kathy. Have a wonderful weekend.
You as well.
Bye. Bye-bye.